A very good afternoon to respected judges, teachers and dear friends. I, Nidhi Manduvra, am here to present my study on the effects of dexamethasone added to lignocaine in axillary brachial plexus block, conducted under the guidance of Dr. Atul B. Vyas sir and Dr. Indu Chadha ma'am at Civil Hospital, Ahmedabad. The axillary brachial plexus block is a popular nerve block for forearm, wrist and hand surgeries. It is much safe as compared to the other upper extremity blocks as it is performed away from the pleura and neuraxial structures. From history point of view, it was first described in New York in 1884 by Halsted, being performed using cocaine under direct vision of the plexus. Many other drugs like morphine, pethidine, clonidine, dexmedetomidine, butorphanol, buprenorphine can be used as adjuvants to achieve a more quick, dense and prolonged block, but dexamethasone was selected as an adjuvant in our study because it has reported to prolong the duration of action of local anesthetics without any major side effects like respiratory depression or hemodynamic instability, which is the case with most of the above mentioned drugs. The aims and objectives of our study was to compare the effect of addition of dexamethasone to local anesthetic drug on the onset of analgesia, onset of sensory and motor blockade, duration of analgesia, duration of sensory and motor blockade, and complication and side effects if any. The study design was a randomized, prospective, double-blinded and controlled study. We included 60 patients in the age group of 18 to 70 years, ASA grade 1 and 2, posted for elective orthopedic and plastic upper limb surgeries. We excluded the patients who did not give consent, patients in ASA grade 3 and 4, patients with bleeding disorders, patients on anticoagulants, patients with severe respiratory disease, prior neurodeficit involving the brachial plexus, any local infection at the injection site or allergy to the local anesthetic drug, patients with a history of peptic ulcer disease, diabetes mellitus, hepatic or renal failure, which is a specific contraindication to the use of steroids, and pregnant and lactating females. We requested on these investigations complete hemogram, chest x-ray, blood urea nitrogen, blood sugar, electrocardiogram in patients more than 40 years to check that the patient lie in our inclusion criteria. The drugs used and the dosages were as following: 6 mg per kg of injection lignocaine 1.5% with adrenaline in the concentration of 1:2 lakh with normal saline, and injection dexamethasone 8 mg was added to the drug solution of the test group. After a thorough preoperative assessment and informed consent, the patient was made to lie in the supine position with the arm to be operated, abductor to 90 degrees, externally rotated and flexed at the elbow. With proper aseptic precautions, a periarterial axillary block was performed with a 22 gauge hypodermic needle. The axillary artery was located high up in the axilla and the correct placement of the needle was confirmed by the visible movement of the needle due to transmission of the arterial pulsations. After negative aspiration for blood, the local anesthetic drug was injected. Onset of sensory block was assessed every 2 minutes by the atraumatic pin prick method, while the motor block was evaluated using the 4-point scale, in which grade 0 for full motor power, grade 1 for decreased power but the patient was able to move the arm, grade 2 for when the patient was unable to move arm but was able to move fingers, and grade 3 for complete motor block. Intensity of post-operative pain was evaluated using the visual analog scale, which has from grade 0 to 10. Patient lying within score 0 to 3 were considered to having adequate analgesia, and rescue analgesia was given in patients more than score 4 in the form of NSAIDs and tramadol. When we compared the time of onset of sensory and motor block, there was no significant difference in the test group and control group, as we can also see in this diagram. But when we compared the total duration of sensory block, duration of motor block and the total duration of analgesia, there was a significant prolongation in the test group as compared to the control group. As we can also see in this diagram, the total duration of sensory and motor blockade as well as analgesia in the test group was more than doubled as compared to the control group. First, I would like to discuss the advantages that we got by using a brachial plexus block as compared to general anesthesia. There was early discharge of outpatients, there is a smooth transition to pain control, there is increased blood flow to the extremity, patient experienced less nausea and vomiting, less drowsiness, and all the complications associated with tracheal intubation are avoided. The axillary route of brachial plexus block was opted for in our study because of its ease, reliability and its safety profile as compared to the other upper extremity blocks. We have used lignocaine with adrenaline in our study to avoid delayed recovery from motor blockade by long-acting local anesthetics like bupivacaine. And the rationale of using dexamethasone was based on studies that have demonstrated the analgesic effect of local spinal corticosteroids in combination with local anesthetics. Dexamethasone is a very potent and highly selective glucocorticoid, and it can be used topically, orally as well as parenterally. Clinical uses of dexamethasone are for treatment of many inflammatory and autoimmune conditions, but glucocorticoids are also used to treat patients suffering from neuropathic pain and complex regional pain syndrome, so steroids have a definite anti-inflammatory and analgesic effect. The mechanism of action by which dexamethasone prolongs the action of local anesthetics is not clearly understood, but the most probable mechanism appears to be by blocking transmission of nociceptive myelinated C fibers and suppressing ectopic neuronal discharges, which it might bring about by altering the function of potassium channels in the excitable cells. So to conclude, addition of dexamethasone 8 mg to local anesthetic drug in axillary brachial plexus block significantly prolongs the duration of analgesia and motor blockade in patients undergoing upper limb surgeries, and the take-home message is adding 2 cc of dexamethasone is a very easily available, remarkably safe and cost-effective method of providing excellent post-operative analgesia without any significant side effects. Thank you.
That was a good presentation, and as I said earlier,
Thank you,
in the
sir.
interest of time, we will not have any discussion.
Yes,
We will move
sure.
on to the next speaker.
Sure.
That was a good presentation. Thank you.